Good day to you all, and welcome to today's TMA's Ask the Expert webinar. My name is Martha Arnold, and I'm a person living with inclusion body myositis. I previously served on the board of directors of the Myositis Association, and it is my pleasure to be the host for today's webinar. I'm joined by today's clinical expert, Dr. Kendrea Garand. Dr. Kendrea Garand is an associate professor at the School of Health and Rehabilitation Services at the University of Pittsburgh. Her educational background includes 4 degrees, including doctorates from the University of Pittsburgh in medical speech language pathology and the Medical University of South Carolina in health and rehabilitation science. She has been a practicing speech language pathologist for over 15 years and holds board certification in swallowing and swallowing disorders, as well as several other speech and language credentials. Her interests include how aging and neurological disease impacts swallowing function, airway clearance, and respiratory swallow coordination. It is TMA's pleasure to welcome Dr. Garand to this Ask the Expert webinar. Dr. Garand, would you like to take it away?
Yes, thank you so much. It is, first of all, just such an honor to be able to be with you all today, especially during this busy holiday season. So I'm just super excited that we're able to share this afternoon together. As some of the questions were coming in, I thought that it might be a good idea to showcase a little bit kind of behind the scenes and setting the stage for, how we actually swallow and what that may look like in somebody that has idiopathic inflammatory myopathy. I will go ahead and just kind of provide this disclaimer that most of my clinical career, I think actually I'm nearing up to 20 years, but a good 15 of those clinical years has predominantly been providing dysphagia services to those with neurodegenerative diseases, predominantly ALS. And as a result of that, I also started getting a direct referrals for patients specifically with inclusion body myositis. So most of my clinical career and all of my research related to the myopathies has really been centered on IBM. Um, However, I will try my best to answer questions related to the other IIM diagnoses as well. So with that, I thought before we really dived into the questions that are coming up, I thought it would be really beneficial to just quickly review how we swallow kind of typically. Although the swallowing process can actually last less than a second, so very, very quick, and we started in utero even before we even entered the world, if you will. Swallowing is just an extremely complex physiological event, really meant to provide our bodies with nourishment in order to allow us to sustain life. The process of swallowing itself, I've already kind of hinted that it's pretty complex. It involves approximately 30 to 50 different pairs of muscles working together, and it has to do so in a really rapid but carefully coordinated sequence. So that means that those muscles are being innervated by at least 5 nerves that are coming from the brainstem, at least 3 nerves coming from our neck region, all to control those muscles rather properly. Multiple areas of the brain, I already mentioned the brainstem, all those have to work together to also manage this process. And then, and as if like that wasn't enough, we also have to carefully time our swallowing with our breathing to make sure that those foods and liquids that we're swallowing, even our saliva, actually goes down the right way and really doesn't enter the airway. Traditionally, and I'm going to go ahead and say, albeit very arbitrarily, swallowing is commonly discussed as occurring kind of in like these 3 phases, if you will. It is important to understand that the swallowing events are interdependent. Some events really almost occur simultaneously. So we kind of moved away from that term, but it's still a nice way to kind of set the stage of in when talking about swallowing. So the oral phase is that first part. It's often kind of subdivided into what we call like a preparatory part and then a transport part. Preparation is all about getting whatever we're going to swallow ready to be swallowed. So things of like, if it's something like a hard solid, like a cookie that we're chewing, we're breaking it down, and that way it's easier to manage and allows us to more likely have a safe swallow. Then we move on to what we call the pharyngeal phase. That's really all about getting whatever we're swallowing down through the throat or the pharynx and into the esophagus, right? Like it's not trying to come back up through our mouths, it's not trying to come out of our nose. And then that last phase is the esophageal phase. And so that's kind of that last phase of that swallowing continuum. That goal is really just to, again, transport what we're eating and drinking down through the esophagus and into the stomach. And it does that through a process called peristalsis. So just this contraction of the muscles, again, helping to propel it down so that it gets into the stomach and stays into the stomach, right? So it doesn't come back up. As clinicians, we often talk about the consequences of swallowing, and typically we relate that to terms of safety and then efficiency. Safety is referring to whatever we are swallowing not going into an airway, right? Particularly our lungs, because that may cause an infection. Not for everyone, but it can. We also consider efficiency, and that's kind of twofold. So the first one being related to that the swallowing events are happening timely, right? It's not taking too long to occur. And the second piece relates to that whatever we're swallowing actually goes down where it's supposed to go and doesn't hang around, like kind of shown in this image, this darker black stuff hanging out in that throat. So I want to showcase a healthy swallowing. So this is a young adult. The resolution is not the best because it's a pretty old video. But just to orient you, so this is the mouth, chin, that's the jaw, this is the spine, this is the airway. As you swallow, you see this tube going to open up behind the airway. That's the esophagus. So as you see, things are moving very quickly. The airway is moving out of the way, nothing is seeping down. And again, what she's swallowing is a little bit dark. That's the barium. If you've ever had a modified barium swallow study done, that allows us to really see what is happening and how their swallowing is going. And you see as she's swallowing, things are going down into that esophagus. And that's what we would typically expect. Every now and then you see a little bit of residue hanging out, and that can be for a lot of us. But she was very sensate to it, so meaning that, she was like, oh, something's hanging out, and I'll go ahead and swallow again. And that's her chewing. You see a lot of action of the jaw up and down. The tongue's heavily involved with that as well. And then when she swallows, again, things are going down and not trying to go out back through the mouth or up through the nose. And then that's going down into her stomach. But what happens if things go awry? And again, I'm going to use inclusion body myositis, in particular IBM. And the reason for that is because those patients tend to have the highest rates of dysphagia, even some reports as up to 84%. And for those that do develop dysphagia, about half of them did have to have a feeding tube. And so that's nearly 3 times more likely than some of our other idiopathic inflammatory myopathies. And so that's why the cases that I'm seeing are predominantly IBM. Now, dysphagia and IBM can be typically diagnosed more later in the diseases, but I need to put the caution out there that it could be the initial symptom that something's happening and may actually be the only symptoms for years. So it is important that if you do start having changes in your swallowing, that those should be reported to your physician, and then they can make the referral, say, to a speech pathologist as appropriate. And these are just some of the things that patients have reported, that their quality of life is affected. They may have had to alter how they're eating or what they're eating. They may complain of coughing and choking events. That a predominant complaint, especially in IBM, is that they feel like food is getting stuck, and they may point to the upper chest or to their neck, and then they constantly have to swallow. Maybe they have to take a little bit of extra liquids to kind of help push that down. So I'm going to show you now just kind of 2 different swallow examples of a patient with IBM. We are fortunate to have this individual that was involved in a research study, and this patient is actually post myotomy. So they had their what we call the cricopharyngeus, which is a muscle kind of at the top of the esophagus that should relax and open to allow what we're swallowing to pass through. Sometimes that can cause some difficulty, and so those fibers need to be cut to allow that to open a little bit more easily. But you can see already, even before I haven't started the video, you see a lot of this dark stuff. That's where that efficiency, that residue comes in. So it's sitting right on top of the esophagus. The concern with that is it continues to build up. Remember that airway is right in front, so it can actually spill over into the airway. And I'm going to try and pause it at the right point so I can showcase. It's hard to see because the shoulder is in the way. There's a little bit, you may have heard of a cricopharyngis bar, a little out, pushing of this muscle more outward, and it's actually obstructing that flow. And right on top is a little pocket that starts to collect that material, and we call those diverticulums. And this was already after he had undergone myotomy the first time. You also see this darker material that is now starting to enter the airway. And you see, not so great at clearing it. A lot of residue that's left, and the patient is trying to do some extra swallows to help clear it.
Yeah,
This
Dr.
is,
Garand, excuse me
yes,
for just 1 second. I
yeah, of
think we've
course.
lost your the video.
Oh,
Has anybody else?
I can see the video.
Okay, then I've lost the
oh,
video.
oh,
Okay.
I'm sorry.
No, 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 no. It's not your problem. It's mine. Please continue. If
And
everybody
it's a
else can
great
see it.
video, Martha.
Everybody else can see it. We're good. My apologies.
Yeah, it's just a one swallow. But you can see way different than the previous video that I showed you. And then this is a view from the front. We kind of do this so we can see how both sides are moving because there can be some asymmetry in the presentation. And again, already looking a little bit different. You see a lot more kind of residue on this right side. This is all this information really helps us develop a management plan depending upon what impairments that we're seeing because swallowing happens behind closed doors. So without us being able to really identify the impairments, it's more difficult for us to carefully design a management plan. And then lastly, when we're thinking that, oh, dysphagia is present, what can we do? And while I'm not a physician, I do want to briefly just talk about there are some medical options, some surgical options, and that include not just the surgical options as I just mentioned, but also medications, steroids. Some patients respond to IVIG. And then some other options would be that myotomy that we just talked about. That's a more permanent option. Before that, the patient may have dilation or a Botox injection to see how they would respond. But on our side, as a speech pathologist, we do behavioral interventions, so not those invasive interventions, but maybe we'll focus on if the tongue muscles are weak, or if those muscles that really help move our airway out of the way are weak, or our breathing muscles is affected. We can try to implement a strength training program, just like you would do for the limbs. We can also do some postures. So that example where I showed there was a lot of collection on that right side. So a great head posture for that would be to kind of close off that right side. So we have them turn their head. And then some diet modifications, making sure that solids aren't any bigger than the tip of your pinky. So that way, if they do go down the airway or down the wrong way, if you will, it wouldn't obstruct. Some patients respond well, thickening their liquids just a little bit. We tend to not do modifications unless that's kind of like a last resort, just because that may impact quality of life, preparation, access to these kind of materials for those modifications to occur. And so that's all for that. So I'm going to go ahead and stop sharing. So thank you for allowing me that little bit of time just to kind of set the stage, if you will, about how we swallow typically and then where some dysfunction can occur.
Fantastic. Thank you so much for that. I think it really helped at least me better understand what the issues were and how they can be addressed. Can you start our questions by perhaps answering a little bit about what types of specific tests could we expect if we had reported swallowing dysfunction to our healthcare practitioners? What would likely happen?
Yeah, absolutely. So typically, if I receive a referral from a physician, so the complaint is that there's some swallowing issues, and they come see me. I'm outpatient, so they would come see me in an outpatient clinic. And typically, what we start is what would be referred to as your classic like bedside exam or clinical exam. So I'm going to, interview, ask you questions. how would you describe your swallowing difficulty? What's a typical day for you? What are you eating? What volume are you eating? How long does it take you to eat a meal? I'm trying to look for those, if you will, the kind of those red flags, those signs that maybe your symptoms may be suggesting that, oh, maybe we need to look at this a little bit more. Another piece of that is actually looking at how those head and neck muscles are working. Remember, I had mentioned that we have some nerves coming out of our brainstem really innervating these muscles. So I can do a cranial nerve exam. So really seeing how those muscles are moving. And you may have undergone something similar with like a neurologist or a rheumatologist. But I'm looking at on the functional side of like how may that influence speech functions and then also swallowing functions. And then I may ask you, provide you something to eat and drink, right? So actually seeing you at the bedside, and I'm looking for things like, how many times does it take you to swallow, say, a teaspoon of applesauce, if you will? Did you cough after you drank a sequence of swallows of water? So again, those are the types of things that I'm looking for. Does anything um, help your swallowing? Like I feel better when I swallow when I do this, or do things harm it? So I feel worse in my swallowing because of this. A lot of my patients will complain of fatigue. So by the time they get to dinner later, especially if they've had a pretty busy day, maybe they just don't even complete the meal because they are too tired and they're having so much difficulty. So those are the kinds of things that we do in relation to like a clinical exam. And then likely, again, because most of this is happening behind closed doors, that we typically recommend an instrumental exam. And so one of those could be that modified barium swallow study that I just showed you. So you're upright, I give you stuff to eat and drink that's coated with barium that allows it to show up on that x-ray, and then we can see it. The other option would be to do where we take a camera and insert it through the nose. That kind of limits our visualization, particularly on the throat area, but it's a very powerful exam. Everything's colored. You can actually get a direct view of that. It's not just this, 2D black and white image that you saw in the modified. Now, if one exam we're offered is another, because they each have their own strengths and limitations, so we may recommend one exam over the other, and that can be further discussed with that clinician that's recommending it. Then, and that's typically a general assessment of what you would experience. So first coming in, getting that more clinical exam, and then discussing whether or not a recommendation would be appropriate to move into what we would call a more instrumental exam.
Perfect. Very helpful. Thank you. So, someone is interested in exercises that would help improve their swallowing difficulties. Can you share some of those with us, please?
Yeah, absolutely. So I think this is where in the literature it's a bit unfortunate, and I'll throw my field under the bus, where there not a lot has been spent on actually researching exercises for purposes of improving swallowing in our myositis populations. So I think, we tend to have borrowed from our physical therapy colleagues or occupational therapy colleagues or exercise colleagues with regards to how an exercise program that includes range of motion, strengthening in particular, can help, our limb muscles. But we've failed to really look at it on how it affects our speech and swallowing muscles. So these muscles of the head and neck. So I'll go ahead and say swallowing exercises in the literature are severely understudied. Our lab is truly dedicated to changing that. Clinically, historically, I have started patients, again, predominantly IBM, on strength training programs, but I approach it like I almost would an ALS patient. I monitor fatigue heavily. I tailor the exercise program to the impairments that they're presenting with. So I don't do a generic like, oh, you always get these 10 exercises, you always get these 10 exercises. It's truly tailored depending upon that exam that we just talked about. So it may be specific exercises to the breathing muscles, it may be specific exercises only to the throat muscles, it may be specific exercises to only the tongue muscles, or it may be a combination of exercises. Again, really depend upon what the exam is showing. So how I would approach that with regards to say intensity is that I tend to start at a lower number of reps, a lower number of sets per week, and a lower number of days per week. And then we titrate them as tolerated. So, if the patient really is self-reporting a lot of fatigue after completion, we back it off. If they seem to be quote unquote tolerating it okay, we tend to ramp it up until we get to a more generally accepted strength training kind of intensity that would be found in the literature. We always want, when we think about exercise program, we want to challenge a little bit to the patient, but we don't want to put them in a state of exhaustion. So I would say it's not, I can't say it's gold standard practice. I can't say that it's best practices. It's something that should be discussed with the healthcare team about maybe being an appropriate option for you. But I would say that I myself, as I can only speak about me, is that I wouldn't shy away from it if I think that's an appropriate response to the impairments that I'm seeing.
That's great. Can you just help us, for those of us who haven't seen you and won't be able to see you in any time, are there a few tongue exercises you could give us or a few throat exercises you could give us just so that people can better understand what the options might be?
Yeah, so a couple of uh so the one thing that I love to say is swallowing is an exercise, right? Because you're using those muscles. And the nice thing about our diet is that they vary, right? We're swallowing things like water, we're swallowing things thicker, like a really thick milkshake. We're eating solid foods. All those work those muscles a little bit differently. So just your daily diet that has a lot of variety is going to kind of be an exercise in itself, okay? The other things that we can offer as part of a swallowing therapy program is really isolating particular structures in their movement. So again, I was talking, so Martha, you brought up the tongue exercises. So we have these devices where we use a pressure-filled bulb. It's usually blue in color. And we actually can do some presses along that bulb. And then we provide biofeedback to you about how much pressure is being exerted by you. And then we can kind of make you work a little harder, right? Or back you off a little bit. And so we can do those. Those are particular tongue presses. We also have some options where we're kind of having you swallow, but in a different way to work the muscles a little bit differently. So a classic one is called the tongue hold maneuver. It's also called the Masako maneuver, and it's where we actually have you hold your tongue between the teeth and then do a swallow. So we're kind of anchoring your tongue so you can't cheat and use it. And it's pretty difficult to do. And so the more you move your tongue out, the more difficult it is. And what's interesting about that one is that's actually not necessarily targeting your tongue per se, but it's really targeting your throat muscles.
Mm-hmm.
Because again, you're anchoring that tongue in the front. And so your throat muscles are like, ooh, okay, I got to work a little bit harder. So there's a couple of, yeah, different options that we can do.
Perfect. We have a question. Does forcefully swallowing help?
So, yeah, so typically, I'm going to, and you can correct me if I'm wrong with the interpretation. To me, when you're saying a forceful swallow, that means a swallow with like a lot of effort behind it. And there's actually is a swallowing exercise that we do called the effortful swallow. And so a lot of times clinicians may try to use visualization like, oh, pretend like you're swallowing, a grapefruit, something that's would be really hard to swallow at once. So a lot of effort behind it. Now, effortful swallow is can be great, and sometimes we use it. I'm thinking like biting into a peanut butter sandwich, right? That's really sticky, and so I may use some more effort. With that effort, we also tend to increase our pressures. So swallowing is a pressure-driven event. That's how that bolus is able to move. And when we promote more effort, that tends to create more pressures. Now, generally, we would think that's a great thing to have, right? That's going to help move things along like they're supposed to. There is a small catch to that, though. Sometimes it actually works against us because if our throat muscles are a little bit weak in an area, those increased pressures actually start creating a pocket. And I try to catch that in that one video. And so you almost have like this outpouching because there's a lot of pressures being done and that wall is pretty weak. And so that can actually create a pouch, if you will. We call that a diverticulum. And then material can start collecting there. Sometimes if it's small and no big deal, nothing will be done, but sometimes it can create a big issue for somebody, and then they would actually have to have a surgical intervention in order to correct that. So I would say most of the times we want those extra pressures because it helps move things. However, there is this caveat. And again, typically we wouldn't want to promote something we wouldn't recommend something like that until we had that instrumental assessment where we can actually see, how beneficial are these things to help improve your swallowing.
Great, thank you. Are there particular foods or textures that I should avoid?
So I would say this is where there's that discussion that needs to be had with you and the clinician, shared decision making, if you will, about we can talk about maybe some foods for you in particular that are in liquids that may allow you to be a little bit safer, a little bit more efficient, but what I would respond back to you is like, but how does that impact your enjoyment of eating, right? So sometimes patients need a little bit thicker liquids, but they don't really like the taste, and it's expensive to buy the thickener. And, it's kind of a pain always having to mix it or always having to make sure it's on hand. So then we would have that conversation about, really discussing risks and benefits of each. So I would say, things that are thinner tends to be more difficult. So like a water, for example. Um, Things that, if you have a lot of muscle fatigue or weakness in the jaw muscles, that can make chewing really difficult. So then we would say, maybe you want to have things that are a little softer so you don't have to chew as much, or that you can use your tongue to manipulate instead. So overcooked vegetables, if you come to my house, you're always going to have overcooked pasta, so overcooked pasta. And again, making sure that if you're preparing something that's solid, no more than the end of your pinky as far as the size goes. And and so this is where also a conversation with the dietitian can come into play as well. I think they're underutilized, but they have a lot of information, also helpful ways in addition to speech pathologists about how we can maximize your protein, your good fats, your calorie intake, even if the volume that you eat may not be as large as that it once was.
Super, thank you. How can I best take care of myself when I start to choke or find that the swallowing has unexpectedly gone wrong?
Yeah, that's a great question. I think so no matter what a diagnosis is, the one things I always tell my patients and their caretakers is to make sure that you've taken a basic life-saving course. That way that encompasses resuscitation efforts like rescue breath, CPR, but also the Heimlich maneuver that you can either perform on yourself if need be, or that a caretaker can also perform. I think I want to make sure that we are understanding the definition of choking together. So we can definitely have things go down the wrong way. I mean, even healthy individuals sometimes have things go down the wrong way, and that can cause us to spit and sputter and cough. I say, don't be afraid of the cough. The cough is your body's natural response that something went down the wrong way and it's trying to get it out. I know it can be very scary. Sometimes you feel like you can't catch your breath when this is happening. And so I would say the biggest thing is I know it's hard in the moment, especially, but trying to remain calm, having your loved ones that are there with you to also remain calm and to follow your lead. Again, spitting and sputtering and coughing, again, that means some air exchange is happening, and that's not obstruction. When it truly is an obstruction, you cannot exchange air, that's choking. And that's when obviously a Heimlich would be appropriate for that. Um, the when I would say don't hit on your back. um, and I think that can be really hard also as a caretaker because you want to do something. The best thing as your caretaker can do is also, again, remain calm. Um, the other thing is like, as you're noticing these things happen, is start keeping a log. What were you eating? What were you drinking? What was happening around you? What helped to alleviate that sensation? What didn't help alleviate that sensation? The last thing I want to say about this, because I think it's also underreported, patients may experience what is known as a laryngospasm. The laryngo aspect is talking about the larynx or the voice box. That can occur when the vocal folds are essentially going into a spasm, okay? So that closure makes it feel like you really can't breathe in, and that is a really scary feeling. Again, by remaining calm and practicing some exercises, even beforehand, so that way if this does happen to you, you know how to respond in the moment. There are a couple of exercises that can kind of help walk you through a laryngospasm. Again, this should only last a few seconds, probably no more than a minute or so. So for example, I train my patients to take 2 sniffs really quick. That's going to help open up those vocal folds, and then really breathe out slowly through pursed lips. So 2 sniffs in real quick, and then a slow breath out. Again, that's going to keep those vocal folds in a nice open position, allowing for you to have that air exchange.
Perfect. Thank you. Thank you very much for that. Are there adaptive tools or utensils that can help me eat more easily? And we've received something on from this meeting. Are there swallowing assistance products, prescription or OTC, that assist swallowing by lubricating the throat, the swallowing mechanism that you know of, possibly use in their practice or would recommend? So if we could put those two together, please. Thank you.
Yeah. So I think with regards to adaptive feeding and utensils, speech pathologists are definitely aware of those, but your go-to person for that is going to be your occupational therapist. So there are definitely adaptive cups. There are cups where you don't have to extend your head back. They have the nose kind of cut out so you can maintain the position. We have cups that only deliver a preset amount, so like a tablespoon or a couple of, not tablespoon, a teaspoon or a couple of teaspoons. So that way it kind of limits the volume that you're consuming because sometimes smaller volumes allow you to swallow more easy. We also have straws that do the same thing. There are definitely multiple plates and utensil options, again, coming from the occupational standpoint to help promote self-feeding and independency and self-feeding. So I'm going to kind of kick that back over to our occupational therapist colleagues because they would be the best option for that. You know, there's a variety of different kind of utensils. There's more weighted. There's things that help cut. There's different straps that you can put in your hand to help with again the utensil use. So your occupational therapist is going to be your best person to go through when you're thinking about adaptive equipment in order to promote feeding behaviors for sure. And then with regards to things of like lubrication, etc. So yeah, there are a couple of things that you can order. I don't know if it'd be like in your general, like CVS or something like that, but and it's predominantly been for pills. So they make some gel coatings where you put the pill in it and that kind of helps slides it down. There are for patients that sustain or that report, really heavily like a dry mouth, dry throat, you feel like things get stuck. It's kind of hard to help move those secretions around. Then some over-the-counter spray. So Biotine is probably the largest company. A lot of our head and neck cancer patients that have undergone radiation, where it's kind of it's kind of their mucosa is burned and dried out. Biotine makes a lot of mouthwashes. The other go-tos are nasal sprays. So that way, all this is one tube that's all connected. So nasal sprays, saline nasal sprays that actually kind of help coat not just the nasal cavities, but also down the throat as well. So there's definitely some options. And this is where I'm going to also give a shout out to our pharmacy colleagues. Our pharmacists are great with regards to pill management. So if you're having some difficulty swallowing your pills, what are some options that are available? Because we never want to cut a pill or crush a pill unless you've talked with your pharmacist. And there's additional ways to kind of help facilitate you swallowing a pill before you may be moved to a liquid form if that's available.
Super. Thank you. So, what signs should I watch for that may indicate increasing aspiration or pneumonia risk? And in a related vein, is there any equipment that would be available that I might want to keep in the home to help in the case of choking?
Let me get that first one, and that second one, I think I know kind of what you're alluding to with regards to the piece of equipment. So to the first one, I would say if you start any change that you're noticing is worthwhile to talk with your physician about, okay? You know your body better than anyone. You know how you've been used to swallowing, and now you're paying maybe more attention to it. But any changes. So the things, like I said, if you feel like, oh, that did not go down the right way, or you feel stuff coming back up, or it feels like it's getting stuck and you're having to swallow like multiple times and chug liquids down to kind of help push it down, that's kind of that red flag. If you're noticing that you are coughing, especially only on like certain consistencies, like, oh, I'm really only coughing on liquids, or I'm really only coughing on solids, that is, or coughing on both, that is a worthwhile discussion to have, especially if you're sitting around the dinner table and nobody else is kind of coughing, but you kind of increase in this frequency and consistency. That's definitely worth mentioning to your physician. The other ones, the other big ones are unintentional weight loss. You step on the scale and 1 to 2 pounds, nothing worried about, but it's 1 to 2 pounds that week, 1 to 2 pounds the next week, 1 to 2 pounds again the next week, and you see this kind of progressive decline. That's where again we're gonna say like, okay, sometimes someone with swallowing difficulty doesn't tend to consume as much, or they may not consume the variety of things that they were doing, and then therefore they can start having this unintentional weight loss. This is what we don't want. With regards to the question about having a device at home, so I know, and I can't think of the company name, so I know it's all active on my Facebook feed as well, where it's kind of like the suction device at home. Again, not a physician, so that's my blanket statement right there. But I will say, though, that uh, it would be worthwhile talking with your physician to see if that's something that can be an option. I do know it's not supposed to take the place of other additional rescue efforts. So the go-to would still be the Heimlich maneuver, if that can be performed. So I'm going to defer that question to more like emergency physicians or emergency personnel for that. And and then and then the other additional aids, again, could be from this feeding and adaptive equipment like we just talked about with the occupational therapy. And then kind of again, as a last resort, we can modify those foods, right? So again, making them softer, avoiding things that are more triggering for you. So I just saw some in the comments was talking about things that are particulates. So we can think about like nuts and rice and things that are kind of crumbly, like a really dry cookie or cracker. That can cause some difficulty. So maybe avoiding those items. And this is also where the dietitian and I play really well, because if things are a little bit drier, thinking about using those extra condiments, using those extra gravies and sauces, pouring some olive oil on top. The dietitian really likes it because it ramps up the calories really easily, but also may allow you to manipulate that food a little bit easier.
Super. Speaking of the dietitian, can you discuss the International Dysphagia Diet Standardization?
Yeah, ITSY. ITSY, we were so grateful for ITSY. Coming as a clinician that had worked at multiple facilities, this really stemmed from, so say if you were in the acute care hospital and they had put you, say, on a pureed diet with nectar thickened liquids, and that was your diet at that hospital, and then you went to an inpatient rehab facility, and then you get your tray, and even though they haven't changed, quote unquote, your diet, the tray looks very different. And so there wasn't a standardization, even though they had attempted to with previous kind of standardization nomenclature. Things were just still different. So you could get bread on one tray at one facility and no bread on the other tray at another facility. So ITSY really came about to try to standardize these different consistencies, not just across liquids, but also across solids, just as a way for no matter where you were in the world, if I said you drank ITSY level 1 or 2 drinks and you were on ITSY level 6 for foods, that would make sense no matter where you were and on what and what facility or what geographic region of the world. So that's where that really derived from. Now, that is what you're actually consuming. That's a little bit different when considering of like how you're consuming it, like how you're whether it's going in the feeding tube, what are you eating by mouth, and the consistency of that, meaning like the frequency of that. So yeah, so ITSE is fantastic. It was supported by not just our national accrediting organization, American Speech Language and Hearing Association, but also was supported by the American Dietetics Association. And so, yeah, and so slowly, so it's been several years now. So I think there are really solid efforts to continue to make facilities aware of ITSE, how to train their staff. And it's really great for us, again, especially because I'm an outpatient clinician, training caretakers and patients of how to, if they have to modify their foods and liquids, how to do that at home to make sure that they're meeting the levels that would be most safe and efficient for them.
Very good. Thank you. So I'd like to pivot now to treatments, specifically some of the surgical treatments, just in the interest of time. Can you talk a little bit about the types of treatments that are used to treat swallowing difficulties, and how long do these usually take before improvements are noticeable?
Yeah, so again, not a physician and not a surgeon. So I'll just, but speech pathologists should be aware of the different treatment options. So typically, I guess I'm going to more so just focus on that top of the esophagus. So sometimes you may hear it called the upper esophageal sphincter, UES, or you may have heard the term CP or cricopharyngeus. That's referring to that muscle that's one of the muscles that's on top of the esophagus. And so again, it's usually closed at rest and it has to kind of relax, allowing to open to allow whatever we're eating and drinking to go into the esophagus. Sometimes that doesn't work so well and it tends to stay closed. And that's not good. And there's nothing that I can do behaviorally. There's no exercise that I can do in order to fix that. So sometimes we do need our physician colleagues to come in and help that. So some kind of first line options may be to do a Botox injection, which would then paralyze it, dilation in order to stretch that back open. Those again tend to be temporary. So if anybody's ever had Botox or dilation, you kind of, they only last a couple of months, maybe a few more months if you're really lucky, but then you would have to get it again. But if a patient responds very well, that's a lot of support for then the surgeon, whether typically it's going to be an ENT or GI surgeon, and then they're like, okay, you responded very well. Well, let's think about a more permanent option, which would be that myotomy. Essentially, for lack of a better term, cutting those muscle fibers to allow for it to remain open more easily. But again, that's not without complications. As far as like the medicine side of things, so things that may be common in some of my myopathy treatments, things like steroids, IVIG kind of options. I would say that in IBM in particular, again, so I'm only going to speak on the IBM side, patients have variable responses to that as far as it relates to an improvement in swallowing. And if they do get a response, it tends to be also only temporary. And some patients get no response at all. Now, again, I'm only going to speak that from the swallowing standpoint. There are other options we talked about the upper esophageal kind of segment or sphincter area at the top of the esophagus. There's also one in the lower esophagus, and there's those kind of same options are also available for that. And those are typically managed by our GI colleagues.
So a lot of information there. I'm going to circle back to a couple of questions that have been specifically asked to see if there's more to be added. Is a myotomy a permanent solution, especially in cases of a CP bar, or can dysphagia recur?
Yes, so I think, and that's why I actually pulled that one case in particular. So that patient actually had undergone a CP myotomy, and you saw that there was still dysfunction. In fact, he still had a CP bar, and he was actually starting to have a diverticulum that wasn't there before. So he started to have that kind of outpouching that was collecting material. So I would say, again, so this depends on a great conversation with the physician about what are the risk and benefits of these options and what outcomes are to be expected. And so the patient may need a refinement of that myotomy. But yes, typically, once you're cutting muscle fibers, then that's cutting muscle fibers, and then you're going to have scarring of that. So yeah, so I wouldn't say it's always the end all be all, but I can also show you another patient that had a CP myotomy and his swallowing tremendously improved afterwards. So again, it's very patient dependent. Of course, it's always going to be related to the skill of the surgeon, et cetera, and just some other comorbidities that should be anticipated. So I think, again, this has to be a shared decision amongst you and the healthcare team about what is going to be the best option. What I have found more often when I still have patients that have ongoing issues is that the focus was only looking at that UES or CP, like in a CP bar, and not paying attention that the patient also had impairments already that were above that. They had the tongue deficits, they had the throat muscle deficits, they had deficits in helping to help protect their airway. That myotomy wouldn't do anything for those other ones. That's only one piece. And that's why I really wanted to highlight in the beginning that swallowing is extremely complex. It's not just the CP or the CP bar. If there's other things, impairments, that myotomy is not going to fix those impairments upstream. So I really like sitting down with the ENT. So I work closely with our ENT colleagues here because they're the ones that are typically performing our CP myotomies. And so we sit down, we review the swallow study and say, I mean, what are you hoping with this myotomy? And do we really think that it's going to gain all the benefits that you're hoping for? And then that way we can have a very honest discussion. And then that way we can see, what are you willing to undergo, to endure? Maybe it's a CP myotomy and then you come back for exercises with me. Maybe we try our exercises first. I just did this with an IBM patient 2 weeks ago, where the ENT and I decided that, you know what, we're going to give it a good college try of performing these exercises. I put her on a very defined strength training program. And then because she was like, I don't want to undergo because she was receiving a Botox injection and they were deciding to go ahead and do a myotomy. She's like, I don't want a myotomy. And so I was like, let's try this and see if we can't help facilitate that. So that's what we did. So again, just these honest discussions.
Very good. Thank you. Here's another very specific situation. I have been having swallowing choking issues for several years that is getting progressively worse. My GI doctor recommended having the POEM procedure. My manometry test showed that I have, quote, nutcracker esophagus, end quote. Can you tell me about this surgery?
Yeah, so nutcracker esophagus would be one of ours that has, so that's esophageal motility disorder. So remember how I said in the esophageal phase, you have these contractions of the esophageal muscles and they run from top to bottom, and they're really helping push right behind what we're swallowing to help push it down. In a nutcracker esophagus, there's those contractions are excessive, like they're too strong. They're normally too strong. And that can cause issues. In fact, pain is a common complaint for somebody with nutcracker esophagus. And so typically when that is first diagnosed, a more I would say conservative measures are typically offered first. So these are really kind of centered around controlling reflux. If reflux is also a factor that was found to be present in that patient. Certain medications like a calcium channel blocker, that's a really common med. Also, they may even try Botox first so that they can find where those excessive contractions are happening, then they'll Botox that area. And if patient responds well to that, then they can talk about the myotomy option. So POEM in particular is per oral endoscopic myotomy. So they're taking the scope and actually going through the mouth. So it's a very specialized scope. And then that scope also allows them, so they go all the way down through the throat into the esophagus, go to those areas, and then they actually cut those muscle fibers that are just too tight. That's causing that kind of nutcracker esophagus, contributing to, not moving that bolus as well as it should be.
Thank you.
Yeah.
An ENT is recommending dilation by itself and dilation with the option of cutting the pharyngeal bar if it appears to be obstructing.
Mhm.
What's your opinion of the second option? And just as a little history, this person had a pharyngeal myotomy performed 11 years ago.
Okay. Yeah, so when we had this, I also I don't think I mentioned this. So CP bars. Again, if you're like looking on that lateral side to side view, what we see is coming off like kind of the back third of the wall, and it looks like a little, almost like a finger protrusion going out. Um, we can see that in older adults, just natural aging can cause that. So it can be like an incidental finding, but it sounds like in your case, because especially because you use the word obstructive, sometimes these are actually contributing to swallowing impairments, right? So when we go to swallow, it's not allowing material to pass down into the esophagus. And so that's an issue. And so we can do some of these options that I've already discussed in order to hopefully help alleviate that from a medical standpoint. So again, Botox and dilation are both options, albeit temporary. And then if the patient responds well, then they would move on to a more permanent option, again, talking about this myotomy.
Good, thank you. So some changes in swallowing can be gradual. How often would you recommend having a barium swallow studies? And can you address oral health in aspiration?
Oh, I really like that last question, that last piece of that question. So I'll go to the first one. How often? Unfortunately, so, you know, in the ALS world, it's best practice for our patients to return to our specialized clinic every 3 months. We don't have that kind of guidelines for patients with myositis. So what I have to do is think about where they are today compared to where they were, like the progression of what that looks like, especially if they're, I don't mean this negative, like in a decline state. You know, how steep is that slope? Um, and then can I think about where they might be 3 months, 6 months, 1 year? So typically for most of my IBM patients, it depends on if I have them on a monitoring program or an active strengthening other therapeutic program. If they're in a therapeutic program, and I usually do like a home exercise program, right? So they're not always coming to see me, and sometimes we can do telehealth to check in. But I have them come back in 3 months. So peripheral changes in exercise typically show up around the 2 to 3 month mark. So I give them 3 months and then I actually repeat their swallow study. Because because I already have their baseline before the intervention and then a period of intervention. And now I want to see, are we on the right path? Did we produce what we wanted? If not, does there need to be a change of plan? Okay. And if so, that's great. Then I can move them. And then did we get to the goal that we wanted? Again, great if so. And then I can put them on a maintenance plan. And then I'm actually checking with them only every year, once a year. But they also know if something were to change and they feel like something changed, then I can bring them back to clinic early. So I know that wasn't like a definitive answer, but that's how I approach my patient populations. So minimum to kind of check in, but they're also going to our myositis clinics here as well. And although I'm not an active part of that clinic like I am in our ALS clinics, I know our neurologists and our rheumatologists well enough that they know they can refer to me at any time. The second piece of that was about oral health, and I'm so glad you brought that up. There is a beautiful study now almost 30, 40 years old, no, 30 years old by now, that really called attention to this role of dysphagia is not the only thing to worry about when you're fearful of pneumonia. And it was such a paradigm shift in our way of thinking because we were like, oh, you have stuff going down the wrong way. You're going to get a pneumonia, so now you don't eat. We've completely shifted away from that, although that myth kind of still perpetuates. But a big piece that came out this, okay, so if it's not dysphagia, it's not just a swallowing problem, what else? Why does some person that we know stuff is going into their airway and going into their lungs, they don't get pneumonia? And why does this person get pneumonia? What are the differences? And a big piece of that, it's not the only piece because it's complicated, but a big piece of that is oral health. Because you can imagine is what you're swallowing is pulling something from the mouth. And if that's filled with a lot of bad bacteria, and then you swallow that and things go down the wrong way, then that bad bacteria can also get into your lungs. Then that, in the setting of like, maybe compromised immune function, other comorbidities, then that may be, that kind of breeding ground of like, ooh, maybe I'm going to get a lung infection as a result of this. But if you have good oral health, right? And then again, occupational therapy is also really good about how you can promote good oral hygiene independently. Um, is keeping that mouth clean, right? So the flossing and making sure that the tongue is clean, going to the dentist, brushing twice a day, all that typical stuff. Because then if things are going down the wrong way, it's not carrying a lot of that bad bacteria with it.
Mhm. Mhm. Thank you. Well, we're running short on time, but there's one last question that I'm sure everybody will be very interested in, and it's kind of in several different parts, but it has to do with how we can find speech and language pathology experts such as yourself in our own communities. So, a couple of questions if you could address. Is it critical for an IBM patient to see a swallowing therapist familiar with IBM to achieve positive results? Related to that, what subspecialty or certification do I look for in a speech language pathologist? And is there something we can do to help these experts who are out in the community know more about how to support patients with myositis in general, as well as IBM? Specific references, exercise programs, web links, you name it.
Those are great questions to end this webinar. Okay, so I might not remember all of them. I was trying to remember them. So first one
Does
about
someone need to have the experience with
right with
IBM to be
IBM.
able to help?
Yeah.
Yep.
So I would say you may not find somebody. So IBM is even rarer than ALS, and that's pretty rare disease. I know many clinicians that can go their entire careers without seeing one. So then I would say find somebody that has just a neuro background. Maybe it's ALS, maybe it's Parkinson's, maybe it's stroke. But those that have a pretty solid neuro background should be able to understand the literature in a way that they could understand the disease process and how that may impact swallowing. So yes, if you can find one, send them to me as well so we can create a nice little network. But you may not be able to find one, so just maybe just a neurology background in particular would be okay. And then you can give them my name if you want. And then the second question about how to find a specialist. So on my credentials, you saw BCS and then a dash and an S. So that's our board certification in swallowing. And we have a website, American Board of Swallowing and Swallowing Disorders, and you can actually say find a clinician. We had that resource available on that website. So that would be a great place to start. Now, does it mean if they don't have those credentials, are they not experts in swallowing? Absolutely not. This is just an additional certification that they can get, but it doesn't mean that they have to have it to be an excellent swallowing therapist. And then the last one was the additional resources. So I have provided um, to TMA a document, I think that's under resources, where all of our publications from my lab in collaboration with others, I have the esteemed pleasure of working with the most brilliant minds around the world with this. So I'm truly grateful. I even highlighted a link to a podcast that I've previously done. And I think I put a couple of links, especially for speech pathologists looking for some more information about swallowing and IBM. I put those links to a couple of my online webinars and courses that I previously have done.
Fantastic. Very, very helpful. And I'm just going to squeeze in one more because there's a couple of questions for this. What can you tell us about phlegm? And is there any way to decrease the amount of phlegm that people have with this disease?
Oh, if I had the magic cure, I would it would it would be a game changer. So phlegm is a big one. So the first questions that I usually ask in response when the patient's complaining about phlegm is like, what does that mean to you? So what does your phlegm look like? Is it thin and watery? Is it ropey, thick? Um, is it is it more when you first wake up in the morning? Is it more after you eat? Like I'm trying to find what the phlegm means for that person. What have you done to be helpful? What have you not done? Some generic, and I mean these are generic recommendations is typically we always first take a look at hydration. Are you actually hydrated enough, right? Because otherwise your body's going to pull, and then that can make you a little bit more dry. Um, and then I also look at like sleep, right? So is there humidification that's allowing them, especially if they're like an open mouth breather at night? Is there humidification that they can provide to make sure that these the mucosa of our mouths and our throat stay nice and lubricated? Again, that nasal spray also helps with postnasal drip. And then the other kind of major piece is reflux. Remember, motility disorders are really common in myositis populations, including DM, PM, IBM. So I want to make sure that the reflux is appropriately managed as well to kind of keep everything where it's supposed to be, and that's in the stomach and not traveling back up. Because reflux can not just travel up in the esophagus, but can actually spill out over into the throat and into our airways. So I also want to make sure that reflux is appropriately managed. But that's definitely a conversation to talk with your physician about as well.
Super. With that, I think we're going to need to let you go. We got to the majority of the questions, and for that, I think we're thankful. Your responses were phenomenal. The response in the chat has been very, very strong about the webinar in general and your amount of information in particular. And just on behalf of TMA and everybody who's attended, we thank you very, very much for your time today.
Oh, thank you all so much. That was wonderful.